Every 40 seconds, someone in the United States experiences a heart attack. According to the American Heart Association, cardiovascular disease remains the #1 killer of women in the United States, surpassing all cancers combined. And yet, only 44% of women recognize heart disease as their leading threat. According to a landmark study published in Circulation by the American Heart Association on acute myocardial infarction in women, women not only experience unique prodromal symptoms, but also present with fewer typical findings and are less likely to receive timely treatment as a result. Heart disease is not a condition that strikes without warning in most cases. According to a 2023 study published in The Lancet, 1 in 2 people who suffered a heart attack had symptoms up to 4 weeks prior, yet most did not seek medical attention in time. The window exists. The problem is that most people over 60, and particularly most women over 60, are not taught to recognize what that window looks like. According to the American Heart Association's scientific statement on acute myocardial infarction in women, women not only experience atypical symptoms more frequently than men, but also face longer delays from symptom onset to treatment and have worse outcomes as a result. Women wait an average of 54 hours to seek treatment after their first cardiac symptom, compared to 16 hours for men. Not because the symptoms are less serious, but because they are less recognizable. Heart disease kills more women than all cancers combined, and yet most women reach the hospital later, receive less aggressive treatment, and have higher in-hospital mortality than men of the same age presenting with the same diagnosis. The term for the warning signs that precede a heart attack by days, weeks, or months is prodromal symptoms. According to the PMC research review on prodromal symptoms in acute myocardial infarction, these symptoms are transient and nonspecific. They lack the dramatic intensity of the heart attack itself, which is exactly why they are dismissed. They may last a few minutes, then disappear. They may come back the next day and be gone by afternoon. They may be attributed to stress, to aging, to a pulled muscle, to indigestion, to a poor night's sleep. But in a meaningful number of people, they are the body's earliest signal that a coronary artery is narrowing, that an atherosclerotic plaque is becoming unstable, and that the sequence of events culminating in myocardial infarction has quietly begun. For adults over 60, this recognition challenge is amplified by 2 additional factors. First, according to Mayo Clinic, older adults and those with diabetes may have no or very mild symptoms of a heart attack, meaning the prodromal signs may be even subtler and easier to attribute to aging. Second, the cardiovascular risk profile for adults over 60 has typically been accumulating for decades: hypertension, high cholesterol, metabolic changes, reduced cardiac reserve, meaning that the consequences of delayed treatment are more severe and recovery is harder. Every minute of delay between the onset of a heart attack and the opening of a blocked artery is approximately 2 million neurons and 2,000 heart muscle cells irreversibly lost. Early recognition is not just awareness, it is measurably life-saving. This video is for educational purposes only. None of these signs confirm a heart attack without medical evaluation. If you are experiencing these symptoms currently, or if they began within the past 24 hours, stop watching and call 911.
Sign number 7. A new disturbance in sleep. Difficulty falling asleep that was not previously present. Waking frequently during the night without an obvious cause. Or waking in the early morning hours with a vague sense of unease, physical discomfort, or restlessness that did not exist before. An older woman lying awake at 3 a.m., aware of something different about the way her body feels, but unable to name what it is, eventually falling back asleep and dismissing the night as stress-related. According to the landmark PubMed study on women's early warning symptoms of acute myocardial infarction, a study of 515 women with confirmed heart attacks, the most frequent prodromal symptoms experienced more than 1 month before the event were unusual fatigue at 70.7%, sleep disturbance at 47.8%, and shortness of breath at 42.1%. The sleep disturbance data is particularly striking. Nearly half of these women experienced disrupted sleep in the weeks and months before their heart attack, yet the symptom was almost universally attributed to stress, hormonal factors, or the general sleep changes of aging. According to the PMC review on myocardial infarction symptoms in females versus males, over 50% of women had a disturbance in sleep from normal within 4 weeks of their heart attack, compared to 32% of men, making sleep disturbance a more gender-specific prodromal sign than is widely recognized. The mechanism is not mysterious. As coronary arteries narrow and the heart begins receiving intermittently inadequate blood flow during the low-demand, lying-down state of sleep, the autonomic nervous system registers this insufficiency as a low-grade alert. The brain translates that alert into restlessness, wakeful arousal, and vague discomfort rather than chest pain, because the ischemia is not yet severe enough to produce classic anginal symptoms, but is sufficient to disrupt the cardiac reserve that sustains comfortable sleep. Any adult over 60 who has developed new onset sleep disruption, particularly when combined with any other sign from this list, should mention it specifically to their physician and ask whether a cardiac evaluation is warranted. The distinction that matters most: sleep disturbance linked to cardiac causes tends to be accompanied by a vague physical unease, a low-level bodily restlessness, or a sense that something is subtly wrong, rather than the purely mental preoccupation of stress-related insomnia. A person with stress insomnia typically knows what they are worried about. A person experiencing cardiac prodromal sleep disruption often cannot identify the reason for their wakefulness because the source is physiological rather than psychological. If you cannot name why you are awake, and this is new, and it has been happening for weeks, that is information your heart may be sending through the only language the body has available before the pain begins. Sign number 6, cold sweat. A sudden, unexpected breaking out in a cold, clammy sweat that is unrelated to physical exertion, to a warm environment, or to any obvious emotional trigger, and that comes with the feeling of pallor or chilliness across the skin, even when the ambient temperature has not changed. An older man sitting quietly watching television in the evening when a wave of sudden clamminess passes across his forehead and chest, his skin cold and slightly damp without any cause he can identify, lasting 2 to 3 minutes, and then resolving, leaving him feeling that something was briefly and inexplicably wrong. According to Texas health cardiologist Dr. Brandy Williams, symptoms of heart attack in women and in older adults of both sexes often present without chest pain, manifesting instead as unusual fatigue, neck or jaw pain, or shortness of breath, alongside sweating.
According to Kaiser Permanente's clinical overview of heart attack symptoms in women, sudden sweating plus other cardiac symptoms can be a heart attack warning sign, and the distinguishing feature of cardiac-related sweating is that it is cold and clammy rather than the warm sweating of exertion or the hot flash pattern of hormonal change, and it arrives without a physical trigger that would explain it. According to the AHA's scientific statement on acute myocardial infarction in women, women not only present with typical chest pain less reliably, but also experience a broader range of symptoms, including sweating and anxiety as prodromal signs. The physiological mechanism: as the heart muscle experiences episodic ischemia, intermittent periods of insufficient oxygen delivery, the autonomic nervous system activates its stress response, which includes peripheral vasoconstriction and diaphoresis. This produces the cold, clammy sweat that is so distinct from ordinary sweating and that represents the body translating cardiac distress into the language of the skin. According to the Prodromal Symptoms Clinical Review, up to 30% of individuals who subsequently had a heart attack reported this sign in the days leading up to the event. The practical test for whether an episode of unexpected sweating warrants concern: did it appear without physical cause, without exertion, without heat, without an emotional trigger, and was it cold and clammy rather than warm?
Did it appear alongside even a brief sense of unusual physical discomfort elsewhere in the body, chest, arm, jaw, or stomach? Did it resolve on its own within a few minutes and leave a vague sense that something had been briefly wrong? If multiple of those descriptions fit, the episode should be documented and reported to a physician as a potential cardiac prodromal symptom rather than dismissed as a moment of stress or hormonal fluctuation. Sign number 5. Extreme fatigue, not the normal tiredness of a physically demanding day or a night of inadequate sleep, but a profound, disproportionate exhaustion that arrives without adequate cause, that makes ordinary activities feel far more effortful than they should, and that does not resolve after a night's rest. An older woman who has always maintained an active household and a full daily schedule, finding over the past several weeks that by early afternoon she is so fatigued she must lie down, not sleepy but depleted, her body feeling as though a simple task like washing the dishes has cost her far more energy than she possesses. According to the landmark PubMed prodromal study of 515 women with confirmed heart attacks, unusual fatigue was the single most common symptom reported in the month before the event, experienced by 70.7% of these women. According to the Wiley Nursing Open Systematic Review of Prodromal Symptoms in Women Before Acute Myocardial Infarction, a study by McSweeney and Crane found that 92.5% of women with AMI reported at least one prodromal symptom, with 87.5% experiencing 3 or more symptoms that manifested months prior to the event. According to Cleveland Clinic cardiologist Dr. Leslie Cho, cardiac fatigue is far more dramatic and debilitating than ordinary tiredness, and it comes out of nowhere. A person's regular activities suddenly become too difficult because of extreme tiredness that has no other explanation. The mechanism is direct. As coronary arteries narrow and cardiac reserve declines, the heart's ability to sustain adequate output during ordinary activity is compromised. The muscles and organs that depend on that output signal their oxygen deficit as fatigue. This fatigue is unlike the fatigue of exertion because it is not proportionate to what the body has done. It is the fatigue of a heart that is working harder than its blood supply allows, and no amount of rest resolves it because rest does not open the artery.
Sign number 4, digestive discomfort. Persistent nausea, upper abdominal pressure or discomfort, a feeling of fullness or bloating that has appeared without a change in diet, or symptoms that mimic heartburn or indigestion but that do not respond normally to antacids and occur during or after minimal physical activity. An older woman who has been treating what she assumes is persistent heartburn with over-the-counter antacids for weeks, finding that the symptoms improve slightly with the medication but do not fully resolve, not realizing that the indigestion-like feeling in her upper abdomen is not related to her stomach acid but to her coronary circulation. According to Mayo Clinic, heartburn or indigestion is specifically listed among the warning signs of a heart attack, and older adults, women, and people with diabetes are the populations most likely to experience heart attacks through this kind of atypical presentation rather than through classic chest pain. According to the Texas Health Cardiologist Overview, women often come in late for cardiac care because they think they're having heartburn or acid reflux, and the anatomy explains why. The esophagus and the heart are anatomically adjacent, sharing nerve supply from the same thoracic spinal nerve roots, specifically the T1 through T4 dermatomes. And when the heart is ischemic, the brain receives pain signals from these nerve pathways and cannot always determine whether the source is the heart or the arm and shoulder that share the same neural wiring. If you have been managing what seems to be recurrent heartburn that appears with minimal exertion, that wakes you from sleep, or that has appeared without any dietary explanation, and you're over 60 with any cardiovascular risk factors, this symptom pattern warrants a cardiac conversation with your physician rather than another purchase of antacids.
The specific features that separate cardiac digestive discomfort from ordinary gastrointestinal symptoms are these. Ordinary heartburn is typically triggered by specific foods, alcohol, or lying down after eating. It's generally relieved by antacids. It does not appear specifically during physical exertion, and it does not tend to appear and disappear within the same short window of time. Cardiac-related upper abdominal discomfort, by contrast, often appears during or after walking, climbing stairs, or any activity that increases cardiac demand, and it resolves when the person rests. If your stomach discomfort has this exertional pattern, treat it as a cardiac symptom until proven otherwise. Sign number 3. Pain or aching in the left arm, shoulder, or upper back. A discomfort that radiates down the inside of the left arm, that creates a heaviness or deep ache in the left shoulder, or a dull, persistent pressure between the shoulder blades that comes and goes over days or weeks without a musculoskeletal injury or strain to explain it. An older man who has been rubbing his left shoulder and assuming he slept on it wrong, who has tried stretching and anti-inflammatory medication without complete relief, who never considers that the pain disappears at rest and returns specifically when he walks or exerts himself. The mechanism behind this sign is one of the most important concepts in cardiac symptom recognition: referred pain. The heart muscle and the skin of the left arm share the same thoracic spinal nerve roots, specifically the T1 through T4 dermatomes. And when the heart is ischemic, the brain receives pain signals from these nerve pathways and cannot always determine whether the source is the heart or the arm and shoulder that share the same neural wiring.
According to the American Heart Association, pain or discomfort in the arms, left shoulder, back, neck, jaw, or stomach is specifically listed as a warning sign of heart attack. According to my cardiologist's clinical overview, referred pain happens because of shared nerve pathways, making it harder to pinpoint the source. The left arm is the most common location for this radiating pain, but it can also affect the right arm, shoulders, back, neck, jaw, or upper stomach. According to Mayo Clinic's heart attack symptom overview, pain or discomfort spreads to the shoulder, arm, back, neck, jaw, teeth, or upper belly in some people. And some people have upper body pain with no chest discomfort at all. The clinical significance of this sign in adults over 60, because musculoskeletal shoulder and upper back pain is so common in this age group, cardiac referred pain is almost always attributed to the shoulder joint, rotator cuff, or spinal condition rather than to the heart. The distinguishing feature, cardiac referred pain, tends to come on with exertion and resolve with rest, unlike musculoskeletal pain, which typically behaves oppositely. Musculoskeletal shoulder and back pain is generally aggravated by specific movements, reaching overhead, turning the neck, pressing on the tender spot, and is not reliably triggered by walking or climbing stairs. Cardiac referred pain to the shoulder and upper back does not change with movement of the affected limb. It follows the pattern of the heart's oxygen demand rather than the pattern of musculoskeletal mechanics. Any older adult who has been managing shoulder or upper back discomfort that specifically appears during physical activity and disappears with rest, particularly on the left side, should ask their physician directly whether a cardiac evaluation, including an ECG and stress test, is appropriate before continuing to treat it as a musculoskeletal problem. Sign number 2. Pain, pressure, or an aching sensation in the jaw, neck, throat, or teeth, particularly pain in the lower jaw on the left side, pressure or tightness in the throat that feels like something being squeezed, discomfort in the neck that comes and goes, or a toothache-like sensation in the lower teeth that has no dental explanation. An older woman who has been telling her dentist about a recurring ache in her lower left jaw for 2 months, having received reassurance that her teeth look fine on X-ray, who has attributed the continuing discomfort to grinding or tension, who has never been told that this specific complaint, lower jaw pain,
without dental cause, is one of the most documented warning signs of impending myocardial infarction in women and in adults over 60. This is the sign most consistently missed, most consistently attributed to a non-cardiac source, and, according to clinical evidence, one of the most specific warning locations for cardiac ischemia in women.
The anatomy explains the mechanism completely. The heart's pain signals travel upward through the vagus nerve and through the upper thoracic sympathetic nerve fibers, pathways that converge with the nerve supply of the jaw, teeth, throat, and neck in the cervical and upper thoracic spinal cord segments. When the brain receives pain signals from these convergent pathways during cardiac ischemia, it frequently localizes the pain not to the chest, but to the jaw, teeth, or throat, areas the brain is more accustomed to receiving sensory input from, and that it therefore identifies as the apparent source. According to the American Heart Association, women may experience pain or discomfort in the jaw, neck, or throat as a primary heart attack symptom. And according to the AHA's scientific statement on women in myocardial infarction, pain in the neck and jaw is specifically documented as a more nuanced and variable prodromal symptom in women that can persist, recur, or build over days, weeks, and months before the acute event. According to Texas health cardiologist Dr. Williams, symptoms of a heart attack in women can present as neck or jaw pain specifically, and women miss it because jaw or neck pain sounds like a dental problem, a tension headache, or a muscle strain from sleeping in the wrong position. According to the PMC prodromal symptom study, pain or discomfort in the jaw or teeth was specifically documented as a prodromal symptom experienced more frequently by patients with the history of ischemic heart disease. According to Kaiser Permanente cardiologist Dr. Ming-Sum Lee, it is difficult for many people to pinpoint where cardiac pain started because the symptoms can appear in areas far removed from the chest, and jaw or neck discomfort specifically may build slowly over time. The characteristics that distinguish cardiac jaw and neck pain from dental or muscular causes. Cardiac jaw pain is often a dull, aching pressure rather than a sharp, localized pain. It frequently comes on with physical exertion or emotional stress and eases at rest. It tends to affect the lower jaw more than the upper jaw. It does not worsen when chewing. It does not respond to dental treatment or pain relievers as expected. And it may be accompanied by any of the other signs on this list, even briefly. Any adult over 60 who has been experiencing unexplained jaw pain, lower jaw pressure, throat tightness, or neck aching, particularly when it appears during exertion and disappears at rest, should seek urgent cardiac evaluation rather than returning to the dentist for a second opinion. Sign number 1. Dizziness, lightheadedness, or sudden near fainting, a sensation that the room is tilting, that the person might fall, or that consciousness is briefly threatened, combined with or immediately preceded by shortness of breath at minimal exertion or at rest, and the appearance of either of these symptoms in a pattern that is new, that is worsening, or that occurs specifically with physical activity. An older woman who has been pausing at the top of her staircase to catch her breath for the past 2 weeks, who felt briefly and frighteningly dizzy when she walked from her car to the grocery store entrance, and who told herself she was simply out of shape rather than recognizing that her heart is struggling to supply adequate blood flow to her brain and her body during even minimal cardiovascular demand. According to the American Heart Association, lightheadedness or sudden dizziness and shortness of breath are specifically listed as heart attack warning signs, and shortness of breath may occur with or without chest discomfort. According to Mayo Clinic, lightheadedness and loss of consciousness are listed alongside chest pain and cold sweat as signs of a heart attack requiring immediate emergency evaluation. According to the Lancet 2023 study, 1 in 2 people had symptoms before their heart attack yet did not seek care in time. According to the Prodromal Symptoms Clinical Review, dizziness and breathlessness represent the ischemic heart struggling to maintain output. And when these symptoms appear during activity that was previously effortless, they represent a significant escalation of the cardiac warning that the earlier signs on this list began sending weeks ago. This is the sign that requires the least ambiguity and the most urgent action. If you are currently experiencing new dizziness or shortness of breath with minimal exertion,
walking from one room to another, climbing 6 stairs, standing up from a chair, call 911. Do not drive yourself to the hospital. Do not wait to see if it improves. According to the AHA, EMS staff can begin treatment when they arrive, and people who arrive at the hospital by ambulance receive faster treatment. The difference between calling 911 immediately and waiting an hour is not inconvenience. It is the difference between heart muscle that can be saved and heart muscle that cannot. Quit smoking if you still smoke. 1 year after quitting, according to the American Heart Association, your risk of coronary heart disease drops by 50%. Control your blood pressure, your blood sugar, and your cholesterol with your physician's guidance. Exercise moderately, sleep adequately, and if any of these 7 signs appears, particularly if more than one appears at the same time, treat it as the cardiac signal it may be and seek evaluation without delay. Watch the next video on screen right now.